the Spinal Truth Show weekly podcast edition. I'm your host, Dr. Caleb Slater, here with Chris, who has a GI system.
So they say.
So this week we are going to talk about GI specific issues, but specifically in the pediatric population, in children, because it's being more and more prevalent in the medical world. Before we get to that, make sure to like and follow us on YouTube, Spotify. We're also on TikTok and Instagram. If you want to reach out to us, you can go to thespinaltruth.com, look at our website to schedule a consult or a session or get more information. All right, so getting started, GI issues, and these are issues that are commonly, they end up being diagnosed as IBS, Crohn's, ulcerative colitis. I'm seeing a good amount of these issues in younger and younger population. I've treated anywhere from an 8-year-old to, 8-year-old and up.
Yeah.
So if we're talking about the pediatric population, 8 to 18. So, and for the people that aren't familiar, I'm a very spine-centric focused physical therapist, at least spine first and foremost. When a patient comes in with any symptoms, knee, elbow, wrist, whatever, GI, I map out their symptoms, but then I look at the area of their spine that could be contributing to these symptoms in that area. I see if there's a problem. If there is, I mobilize it. I show a patient how to mobilize it and strengthen it in a range to take pressure off a nerve and see if their symptoms change.
Gotcha.
And from what I found in my career, the more and more that I do this, the more and more we're able to affect the patient's not just symptoms, but likely their underlying cause. And I found that for a lot of these GI symptoms, their actual underlying cause is a spine issue, specifically at the TL junction, so the lower thoracic upper lumbar area. It's one of the main areas that innervates your intestines.
Yeah.
So if this nerve signal isn't getting to the intestines, which are smooth muscle, aren't contracting as well. Their job is to contract, move waste, blood flow, nutrient exchange. The waste is being more stagnant, nutrient exchange isn't occurring. The muscle contraction isn't causing blood flow as well, so the intestines basically stop performing their job, and that can lead to all of the same symptoms of Crohn's, including inflammation in the intestines, including bowel obstructions or chronic diarrhea or gas or bloating or abdominal pain, and as well as even a deterioration of the tissue itself that could very well translate into ulcers or other lesions.
Yeah, and I've seen it since working with you now for over a year, but you've treated people who have been on biologics for years, who've been dealing with symptoms for years with Crohn's, ulcerative colitis, and after working with you and doing the movements and stuff like that, essentially got off of those biologics, symptoms reversed. So I've seen the effectiveness of it, but to me that was understandable that they developed so long because they're older, they've been dealing with these things for years and years and years, but when you say children, it's a different...
Yeah. You're absolutely right, because as we age, things deteriorate, right? And you can say toxins build up or forever chemicals or plastics, right?
Microplastics and everything.
Right, everywhere. You can say and it even makes sense if it's a spine issue, your spine deteriorates over time.
Right.
But in a child, that's not the case for all of that. So why are they getting symptoms? And before we get into it, I did want to mention that, it's one thing to hear from us.
Yeah.
But it's a completely different thing to hear from patients that have gone through it. And on our next podcast next week, we will interview the parents of a child that's gone through this treatment. They actually live in a different country, so they've solely done it through telehealth, which a lot of my patients are that these days. And you can kind of hear what he went through, what he was diagnosed with, how long it's been, and then his pretty quick recovery with this program. So I understand the skepticism. I completely get it. I never thought I would be a PT treating GI symptoms, or B, talking about it on a podcast. And so I get it. But if you want to hear a little bit more, listen to today's podcast. And if you want to hear from somebody that's been through it, stay tuned for next week.
Yeah. All right. So let's get talking about how these symptoms manifest in children.
Okay. They're very similar in the adult population.
Okay.
You know, it's normally abdominal pain, and it's normally a good amount of diarrhea. It's either constipation or diarrhea, but normally it's diarrhea. They're normally going a whole bunch. They have urge incontinence where they really have to get to the bathroom pretty quick. One thing that's a little bit more specific to the child population that seems more prevalent is waking up at night to have a bowel movement.
Interesting.
And this is something, honestly, I didn't even know people did.
No,
Until I started treating this population.
Yeah.
And some adults will do it, will wake up to go to the bathroom. You know, the adults that have been diagnosed with Crohn's or ulcerative colitis or IBS or something like that. But it seems like in the pediatric population, it's much more common.
So are they having like stomach cramps or something that wake them from sleep?
So they normally just wake up with the urge to go.
Gotcha.
And from my view, explaining it is, you don't really think about this when you sleep, but if you're on your back or you're on your stomach, your spine's actually in a good amount of extension. Your low back's in a lot of extension, putting a lot of pressure on this TL junction. Even if you're on your side, unless your knees are all the way up to your chin, your low back is still extended. So this constant extension on your spine over time eventually, starts to mess with the nerve. The nerve signal now is getting where it's going is getting irritated, it's spasming. So if it's getting to your colon, the colon the intestines might spasm a little bit, and then that gives you that sensation.
Gotcha.
So you wake up out of sleep with that urge.
That makes sense.
And this is one of the first symptoms that improve when we start treating these patients, so it's kind of cool. It's nice to see that relatively immediate change, that within the first 1 to 2 weeks, most of these pediatric patients are saying they no longer wake up to have a bowel movement.
I have to assume, just talking to people in general, sometimes communication skills are lacking, but communication skills amongst children even harder to determine.
If I'm being frank, I don't enjoy treating children
because
for the most part.
How are you doing? Fine.
Right.
All right. Elaborate. What's wrong? Yeah.
I will say, in this population or this diagnosis or these symptoms, the children seem to be a little bit better, partly because they've been through so much medical rigmarole.
True.
I had one, and you can actually see her on TikTok in our testimonials or our Crohn's playlist, I forget, but she was like such a precocious 9-year-old. She was telling me about her symptoms, and I was like, it was almost a little sad because she was speaking in medical terms.
She's very eloquent. In her,
it was almost like, man, like for her to have been through it this much, where she has that much control over knowledge of it. Yeah, you're like, that's a little sad.
Yeah, so. It is sad. But
thank you for watching the Spinal Truth Show. I hope you're finding this information helpful. If you're out there and you're still in pain and you're looking for relief, we have some solutions for you. You can schedule a consult with me or a session, but if that's not in the budget, we also have some options that are self-guided at home. You can go to thespinaltruth.com. We have courses set up right now for arm pain as well as for neck pain. They are geared towards you. They are a 4-week course, 60 videos that are self-guided by an expert in the field that you can do from the comfort of your own home at your leisure. They will take you through step by step the typical approach that I take with patients. The expectation is that they will provide significant relief over these 4 weeks. So if you're looking for something better, something different because you're not finding the relief, go to thespinaltruth.com, sign up for one of these courses, and get the right treatment, see the difference.
So the symptom that you're talking about, the nighttime bowel movements, that's obviously, that's noticeable. It's not something I have to describe.
Right.
So besides that, is there something that they kind of all say?
All right. So a lot of them have some form of lower leg symptom. Okay. A lot of them have been diagnosed at one point with plantar fasciitis, and it's not getting better. Surprise, surprise, right? A lot of them have maybe, I would actually say maybe about half of them have a history of back pain, but it either went away, quote unquote, or it's not the predominant symptom.
Man, that's crazy to hear.
You know what? One thing that is, it's present in both the adult and young population, but seems more evident in the younger population, is they can't squat. If you tell them to squat, they'll get to like not even 90, and they'll just start to fall over.
Wow, really?
Yeah, and
I'll have to ask my kids.
Yeah, I see it more and more common, and you think about when you think about squat, if you're online or whatever, the inability to squat deep is constantly blamed on your ankles and your knees, like poor ankle and knee mobility. And I get that, but people don't realize that spinal mobility plays a huge role in your ability to squat. So if you don't have that, you basically can't squat. You'll get to a point where you just can't go anymore without losing your balance. And you should be able to, at any age, pretty much, you should be able to do a full deep squat all the way down to the ground.
Gotcha.
And in these kids, pretty much none of them can.
I'm sure we're going to dive more into the reasoning of why you think these children, this is starting to be a phenomenon maybe. But I grew up in the 90s. You grew up probably in the 90s too, I assume we're a similar age. I don't remember having back pain as a child.
Well, and all right, so getting into the reason, it's twofold. And I think the two kind of serve each other. The child's either severely inactive, or they're almost like severely overactive, but when they're not active, they're underactive. Does that make sense?
They go
from one extreme to they go from 0 to 100, right? You know, because back in our day, when nobody had an iPhone, nobody had a phone, nobody had. Like I was even telling my kids this literally last night, that most houses actually only had one TV. And then it started to get more popular that maybe the parents would have a TV in their room. And then all of a sudden the kids would have a TV in their room. But like this was over years, decades. So when we weren't doing something, or when we weren't playing a sport, we were still relatively active. The kids these days, when they're not playing a sport, they are, like my kids, they get home from camp or school, computer, they like run up to their tablet, room and they're in their bed on their phone.
How do you feel about us changing the podcast name to Two Old Men Complain About Children?
Oh, I have more material on that than I have about the spine.
PT, no, but you're right. It is a completely different lifestyle now.
Well, and then when you go to the sports, even the sports is different, where now like kids are doing travel all year round. Kids are in 3 different of the same activity. They're in 3 different softball leagues, or 3 different basketball leagues. So they're like almost overactive in that sense, and they're coming from a position of pretty much like a weak core because they're not doing a bunch of stuff in their downtime. A lot of people talk about like 10,000 steps a day, and that's great. But one thing that's maybe even a little bit better is just being kind of constantly active. And again, for these kids, they're either sitting on their phones really hunched over, or laying in bed, or they're doing these high level sports that we really didn't used to do until maybe you got a little bit older, like high school.
Yeah, I mean, I've told you before, my daughter, especially my oldest daughter, she's in dance, but she's in dance nonstop. I think she takes like 19 classes or something at this point. She's in pretty much every night, and she goes to a dance school. So I say, you're overdoing it. And when she's not dancing, it's like, what are we doing? I'm going to sit. Like, you're just sitting. It's like waiting for the next dance moment. Right.
Well, all right. And so another thing is a lot of these sports, and that some are more than others, affect a lot of extension moment of the low back. So this is cheerleading. This is gymnastics. This is dance. This is sprinting. This is, if you're playing football, if you're a lineman, you're getting pushed up, pushed backwards every time.
And these are activities we're saying that are causing trauma, right? It's just
I don't know. Like wear and you can kind of say trauma. You could say micro trauma.
But I mean, like football, you can get hit and get.
So it's not like a trauma. It's repetitive movement over time, and you're moving it constantly in the extreme of one direction, and you're often not undoing it and moving into the extreme of the other direction.
Okay.
And that's pretty much what I do for these patients. Is obviously, every patient I evaluate their symptoms, I map out their movement, I see where they're stiff or tender, if they're in person, and I push on individual levels of their spine, but it keeps being consistently the main area of tenderness is that TL junction. And again, like...
tell me where the TL junction is. Because I've heard TL junction, but I'm not...
Let's say like 2-3 inches above your belly button.
Okay.
Somewhere around there.
So that spot is painful for them?
When to touch, but most of the time they didn't realize that it was painful. Including and you would think like, hey, them sitting against a chair, lying down on the ground, you would think like that would hurt. It's like specific pinpoint touch to that area.
Okay. So when they are complaining about back pain, it's not necessarily a getting up and down back pain, it's just when that spot is touched, is what you mean?
No, well, a lot of them have a history of back pain.
Okay.
I say about 50%, right?
Yeah.
But back pain, it's like normally diffuse back pain. And that spot, by the way, what I've noticed is that it kind of has a referral pattern in kind of an upside down V to like the buttocks area.
Okay.
So a lot of people, they'll say they have low back pain or buttock pain, but it's actually radiating from that spot higher up. So again, why do things get misdiagnosed? Because a lot of times in our body, the area that we feel it isn't the area where it's coming from. And maybe a good analogy with this is like if your power turns off or if an outlet isn't working, you first look at the outlet to see if there's a problem. You maybe try plugging something different in, but then what's your next step?
Yeah, it's the circuit breaker.
It's the circuit breaker, right? And that's kind of our body where a lot of the problem, you're seeing it at the outlet, but the problem is at the circuit breaker. You're seeing it at your feet, but the problem is in your low back.
It's a good analogy. Did you just come
right?
up with that one now?
I think a patient actually said it. I know. I take credit for it, but no, a patient said it.
All right, that's a good one though.
Yeah, it is.
That.
So that's why I stole
it's
it.
Very clear.
Yeah. Because before I was using.
You had a whole.
Well, I was using water through a hose, and it wasn't as good. No, the circuit breaker's better. Yeah,
it makes sense.
Yeah. So all right. So a lot of commonalities in the activities that they've done, their symptoms, and again, their symptoms. We're talking all the symptoms that you would get. A lot of them have been diagnosed with ulcerative colitis or Crohn's. They've found inflammation or other findings on testing, such as lower endoscopies or imaging, right? And a lot of them have done treatment for biologics. A lot of them have been on prednisone at a certain point, and then they've done biologics like Humira, Skyrizi, Stelara, Entyvio. Harsh medications.
Yeah.
And by the way, these are pretty much lifelong medications. Like if anybody out there is taking these, was there ever a plan to get off of them? Like when the doctor was prescribing them to you, where they say, all right, we're going to do this for this amount of time, give your body a chance to heal, and then we're going to start tapering off.
Yeah, those kind of treatments seem like they're life-changing. Like you have to adjust your diet, you have to do this, and you have to do this, and this is just the new normal.
Well, and a lot of these patients too, again, by the time somebody finds me, and I get it, I'm a physical therapist on the internet saying I can treat your GI symptoms.
Yeah.
Like by the time you're desperate enough to see me,
you're like, whatever.
You've done all the food changes. You're like, your parents have changed your diet. You've done your FODMAPs. You've done your elimination diets. You've done all the holistic stuff you can. You've been to different GI specialists. A lot of them have traveled to different these renowned GI specialists throughout the states or wherever they're from. They've really been through the ringer. Nothing's really worked.
Yeah.
And that's another common finding for a lot of the patients that I treat, older or younger, is whatever treatment they've been given has really just managed their symptoms. Mm-hmm. Like it wasn't like, hey, as soon as I started Humira, everything was hunky-dory.
I was back to normal.
Yeah, it was like, I still have flare-ups, it's up and down. I still go to the bathroom a lot, but it's better, So again, kind of another common finding is that the treatments that are given to them still aren't really moving the needle as much to where they're not seeking further intervention.
Gotcha. So you had said earlier that children will express back pain at some point, but you also had mentioned a lot of them get diagnosed with plantar fasciitis. So what is the relation there?
Well, again, so if you have a problem in your back, your sciatic nerve innervates your feet.
Yep.
So if you have some pressure on the sciatic nerve or pressure on your lumbar spine, eventually you'll probably get symptoms down your leg. A lot of them, there's two main common findings in the lower extremity for adults and kids. I think more so adults, they'll have hip pain, like hip groin pain.
Okay.
Especially like if they try to go into a deep squat, like they feel a lot of pressure in their hips. And again, for the adults as well, they'll have symptoms down into their feet, and the symptoms will be pain, numbness, tingling, but it'll get misdiagnosed as plantar fasciitis. And if you've been following us for any amount of time, numbness and tingling isn't plantar fasciitis, but despite that, they'll still get diagnosed with it. Pain obviously can be plantar fasciitis, but if it's on both sides, if it's there at rest, if it's not responding to treatment, then it's probably not plantar fasciitis. And most of the time, that's what I found. And these patients, in a pretty high percentage, I want to say like maybe 70, 80%, have some form of lower leg issue, and plantar fasciitis is the more prominent diagnosis.
So with these children who have had plantar fasciitis diagnosis and are now dealing with Crohn's or ulcerative colitis symptoms, and you help them or treat them, I assume that's also in some way treating their plantar fasciitis symptoms.
Yeah. Well, and so you know the term like canary in a coal mine?
Yeah.
You're looking for, like the canary was there because they're more responsive to small changes in air quality. So if the canary wasn't upright, you're getting out.
Yep.
Probably a bad analogy. So if somebody, but we're looking for, the first thing that we're looking for to change with these patients is actually their orthopedic symptoms. That's our sign that we're going in the right direction.
And that's because that's kind of the end line of the nerve innervation?
So it's a good question. It just seems to be like the orthopedic symptoms, they're easier to treat and make respond. Hey, just a quick break here and then we'll get back to the show. If you're out there and you want to see if this is the right approach for you, you can schedule a consult or a session with me. Go to thespinaltruth.com. At least set up a consult within 30 minutes. I will listen to your symptoms. I will go over your history. I'll go over what the approach I would take for you and the results that I would expect. My goal is to save you from continued pain, failed treatments, and prevent you from getting surgery. So go to thespinaltruth.com, set up a consult, and let me go over your symptoms. Now let's get back to the show. For your GI, there's so many other factors on your diet. If you've had chronic inflammation in that area, even if you are taking pressure off that nerve and the intestines are now working properly, it does take a little bit of time to maybe heal and resolve. But orthopedically, in general, if you take pressure off a nerve or if you restore movement to a joint, you see improved range of motion, improved strength, decreased symptoms, pain, numbness, tingling, that improves pretty quickly. So we use that for the first 1 to 2 weeks. I'm really expecting that the main symptoms changing are the orthopedic symptoms.
Gotcha.
Then it tends to be the frequency. The patients now all of a sudden, they were going anywhere from like 15 to 20 times a day, maybe even more. Like I think the highest I've had is it's like 30. And a lot of times it's in the morning. They're going a lot in the morning. That starts to improve, as well as nighttime bowel movements improve. That's kind of like week 2 to 3. That's what I expect to see. Then it tends to be the form. Now all of a sudden week 3 to 4, somewhere around there. And everybody's a little bit different. But now all of a sudden, where it was only watery diarrhea, now it's more normal formed. Also during this time, patients are having, if they were having blood in their stool, they're having significantly less or no blood in their stool.
And maybe this isn't quite related, but having done like diets and changing what you eat, usually that reflects after a few days for me, like the way my stomach reacts and stuff like that. Usually it's not like if I just start changing my diet the next day, you know what I mean?
Yeah.
So is there like
you're not expecting an immediate change.
Exactly.
With that. And so I count when I treat these patients and their parents, I give them this, let's say roadmap or timeline of like what to expect. And everybody's a little bit different. I actually had a few patients recently, and one of them pediatric, where he was having a bunch of bowel movements in the morning, always diarrhea, never ever formed, and a good amount of blood. And after the first visit, in that first week, he just started having less bowel movements, normal formed, minimal to no blood.
That's crazy.
In 1 week.
That's 1 week,
Yeah. And it was almost pretty much like by the next day, symptoms had changed to the point where the parents were like what's going on?
Yeah, what happened? All from some movements.
Yeah. And you know what the cool thing is that I've seen in the kids kind of talking about their common symptoms? Another finding is it's not fatigue, but it's low energy.
Okay.
You're seeing a lot of low energy. Like this one kid I was treating recently, on his first visit, he's just like, he's almost like slumped in his chair. He's barely engaged. And on our most recent visit, he wanted to do an entrance. He like jumped into screen and he was like high energy. And think about it, if you're not getting the nutrients absorbed, right? If you're going to the bathroom this much, if you're in pain, like that starts to affect your quality of life. So he specifically, like, he could really only stand for maybe like 10 minutes at a time without starting to get some symptoms or fatigue. Like his symptoms was fatigue in the legs. He could kind of same thing with soccer, only like 10 minutes. His parents were saying that he's playing a lot of just video games sitting in a chair. And part of it was just he didn't have the energy to do anything else.
So what activity he was playing soccer a lot? So is that?
Well, so He's overseas,
Okay.
so he was playing football. Hey,
Of course.
if you want
No, we want to be respectful
to, right?
of
Yeah.
yeah. I don't even I never watched
No,
soccer,
I'm
football.
not really a fan.
I'm not a big
If you want
fan.
me to watch, make the goals more frequent. So
Yeah.
make the goalies smaller, make the goals bigger, make the field shorter, take people off the field, do whatever you can, but let's get a normal game 7-6.
Or what if you put it on ice and let people fight each other?
Yeah, I mean, there's a lot of, let's get some weapons in here. There's a lot of ways to Americanize.
Yeah.
But, yeah.
So that was kind of the catalyst of his back problems?
What?
Soccer? Football?
Oh, I
or
don't know.
was it just lifestyle stuff? Because you're talking about like commonalities amongst these.
Yeah, it's hard to say. So again, soccer, it's a lot of running. Running is
Yeah.
an extension moment of your low back. And if you go from that to just sitting and not, you really end up with like, a lot of times, like poor core mobility, poor core strength.
But nothing, the hard thing about this is there's not like one moment in time to pinpoint.
Often there isn't, no. Yeah.
So you have to kind of piece together out of people's lifestyles and activities like where the problem starts, right?
Yeah, and then for me, the nice thing is I really go off of symptoms and movement.
Yeah.
I'll start to look back to try to categorize this better for like why was this, but it's so all over the place and people aren't realizing what they're doing to their bodies during the time they're doing it. They're not biomechanical experts, right? So I can start to clump together commonalities of these patients, and that's pretty much what we're talking about here. But I've had patients that they haven't been in any sports. I'd say the majority of them, though, were in some form of dance, gymnastics, cheerleading, soccer, volleyball is another one.
Okay.
A lot of extension moment. I did have a football lineman.
Okay. Well, let me ask you this, because I know a lot of people out there really like this. If they were to get an MRI or imaging done, would this show anywhere, anything in their back that would reflect this?
So that's a great question. It could or it couldn't.
Okay.
The upper lumbar spine is less viewed on an image. Normally it's the lower lumbar spine, L4, L5, L5, S1, that gets a lot of the attention. Mm-hmm. We've talked a lot on this channel how imaging is a lot more misleading and inaccurate than people realize. Remember, it's taken into position of comfort.
Yep.
It's a snapshot in time. You're not getting muscle contraction. You're not getting loading to the discs. You're not seeing neural tension. Even if you do see pressure on a nerve, that pressure on a nerve from a disc or whatever, from a collapse of your foramina, so like little opening on the sides of your spine, that pressure could cause no change to the nerve conduction. Or you could not see any pressure on the nerve, but when they stand up, now all of a sudden there is, and that causes that change. So could they find something? Yes. Often they either haven't been imaged for their low back, it's purely been their GI system.
Yeah, I assume that's the most people.
Or if they did get imaging, there wasn't significant findings. Yeah.
Well, I mean, I assume most people with GI symptoms never even think that it could be coming from your back.
But no, it's a good question. Yeah. I'm not a fan of imaging for chronic symptoms, or for symptoms that aren't from trauma, or that don't paint a picture that you're looking for something more nefarious, like a space-occupying lesion, like a tumor or something like that. Mm-hmm. And there's signs that you're taught in the medical world of, hey, this is more indicative of a tumor, right? If that's the case, yeah, you need some imaging to rule it out. But imaging for your spine to see a disc issue or herniation, a spinal stenosis, facet arthritis, spondylolisthesis is a little bit different, but spinal stenosis, like in order to view that, those are all normal findings in pretty much any age of life. And by the time you're 40, it's close to 100% that you're gonna have some of those.
Yeah.
Throughout multiple body parts, your spine, your joints, like you'll have degenerative joint disease or a meniscus issue or a labral tear or a rotator cuff issue. Like by the time you're 40, if you don't have any findings on an image, you would be the exception.
So then the problem lies within, maybe that is potentially causing a problem, but maybe not, but because they saw it, they're going to just assume that is the problem.
They're just gonna assume that's the problem, right? And a lot of times, they assume it's the L4, L5, L5, S1, but there's symptoms from higher up.
Gotcha.
Like the hips, groin is primarily innervated by like your T12L1 area, so your upper lumbar spine, lower thoracic upper lumbar spine, right?
Yeah.
So like you're having symptoms higher up, but how do you equate just the L4, L5?
Right.
And it happens a lot.
Gotcha.
And for me, again, so imaging, especially with X-rays or a CT scan, like it's exposing you to radiation. It's costly, and it can be misleading. For me, I'd much rather listen to your symptoms, how they behave, how they respond to different positions, you know, when you sleep, when you stand, when you walk, when you run, you know, how you move in the moment, how your symptoms behave if you're in person, how your spine moves when I press on it, and is it tender? And then, I know this sounds a little counterintuitive, but how you respond to treatment. If we treat that area, what happens to your symptoms?
Yeah.
And for me, that's a much better picture of you, your symptoms, your body, than a static image.
Agreed. And that's the problem, is if you get that diagnosis, it comes with you. And so when you go to the PT or whatever, they say ahead of time you have plantar fasciitis, so they do their standard treatment for that. And when it doesn't work, then that's where you get into the injections and the surgeries and all that stuff, right?
Yeah.
Yeah.
And with the GI symptoms, you start with, most of the time, like kids are started on some form of like Metamucil or, you know, Tums or some form of over-the-counter treatment for acid reflux or bloating or gas or abdominal pain or diarrhea or something like that. And then pretty quickly they're moved on to the more aggressive steroids and biologics.
So, for one, it's hard to take you seriously with anything.
I just spilled coffee all over myself. This is the worst podcast. I'm in a bad mood for the rest of this podcast now.
But if the medications for Crohn's and ulcerative colitis work, why aren't they better?
Yeah, it's a great point.
And why?
Well, why is it more prevalent year over year if those medications work?
Right. So have you treated anyone who's been on those medications that are now off of those medications?
Yeah, a good amount of patients, actually.
And they are still better?
I check in with them. The longest running person we have so far is about 5 years old. 5 years removed from stopping medication.
And they're still off of it?
They're still off of medication, doing well. I have another few that are in like the 2 to 3 year timeline, but at a certain point, you know, I lose touch.
Sure. But and I assume if they had a problem, they would come back.
Ideally.
Yeah.
You know. So I had one patient, you can see her interview actually on this channel. She was on prednisone for the better portion of, I think, 5 to 7 years. And so prednisone, and like, I mean, not coming off of it. Every time she would start, don't quote me on this, somewhere around 40 milligrams, it might have been 20, but every time she got down to 2.5, or somewhere around 5 to 2.5, like, because she was trying to taper off her dose, because you're not supposed to be on it for a long time. She would just get she would get a flare up and she'd have to up her dose again. And that was for the better portion of 5 to 7 years. And after working with her for a few weeks, she was off medication.
So are those medications designed to bring down the inflammation of that area?
The prednisone specifically, yeah. And then the biologics, yes.
So essentially what could be happening is because of your back problem, you're getting a lot of inflammation and the prednisone's fighting that?
Right. So remember, inflammation isn't a diagnosis. Inflammation is a symptom.
Right.
Right? So, all right. And another thing that people need to realize with this is there is no test that confirms that you have ulcerative colitis or IBS or Crohn's. There's a cluster of symptoms. There's findings on tests and imaging. So findings on a CT scan or a colonoscopy would be, you know, obviously inflammation, strictures, fissures, ulcers, you know, stuff like that. But those are still findings, those are still symptoms. And they can be caused from a nerve issue not getting to the area not contracting properly, you know, what we talked about. So there's no test that confirms Crohn's or ulcerative colitis. You can have genetic factors that predispose you, you know, but again, that's just a predisposition. That's not an absolute that if you have this genetic marker that you will have Crohn's or ulcerative colitis.
So are you saying that Crohn's is something, but often misdiagnosed?
Yeah, all right, so that's a really good, because people are out there going to say that I'm saying Crohn's isn't a real thing.
Yeah.
No, I'm saying that all the same symptoms can be caused by a back issue, and it's never looked at. So what do I want out of all this, right?
Yeah.
I want people that have a whole host of symptoms going to their doctor, and early on in the diagnostic process, somebody takes a good look at their spine, pretty much the way that I would, listen to their symptoms, watch them move, push on their spine, see if there's tenderness or a problem in these areas that could cause your symptoms. And if so, spend about 4 to 5 weeks of properly treating that area before you go down this rabbit hole of medication, injections, surgery. That's it.
Yeah.
That's all I want.
Yeah, but sometimes people don't want to hear that, it seems.
It's weird. It's weird how much pushback we get. You get people out there, they're like, you're going to kill somebody. I'm like, by telling them to bend their spine a little bit in a normal range of spine movement, you know, with progressive amounts of load and force and range, I don't think that's going to kill them compared to the lifelong cortisone and biologics. And
the pushback you get for telling someone to bend over with their spine as opposed to take this harsh medication, like I don't quite get it. They just, maybe they think it's too good to be true, but it's not even like you tell them to do these movements. There's still, the onus is on them. They have to put in the work. It's not like you just do it once and you're cured.
Right.
You know what I mean?
Well, and again, I say this for pretty much any medical condition. There's always exceptions, but for pretty much any medical condition, if you're doing treatment, within the 4 to 6 weeks of doing treatment, and part of it's on you. Like if you're not putting in the work, like if it's a physical therapy and they give you exercises, you're not doing them, well then it's not going to work. If they give you medication and you're not taking it, well it's not going to work. But if you're putting in your effort and you're following instructions for 4 to 6 weeks, if you're not seeing relatively significant improvement, and this is somewhere around 50%, you know, like it could be 20%, it could be 25, you know, but you should be saying, hey, what I've been doing has absolutely caused a change. You should be able to say that by 4 to 6 weeks. And that change should be relatively significant, again, somewhere around 50%. And if that's not the case, you're probably getting the wrong treatment or to the wrong area.
Okay. So going back to the core subject of these GI issues in children, is there a difference then in between what you see in the adult versus child?
One of the biggest differences is how quickly they respond. Kids, it's normally like real quick.
Why do you think that is?
They're younger, right? They're more mobile. Their discs are more expanded's not the right word, but open's not the right word. Their discs they've got better discs.
Everything. They're just their bodies.
Yeah, their ligaments are more mobile, muscles, tendons. And they haven't had their symptoms for as long, typically, right? Like if they're 12, they've probably only had these symptoms, hopefully, for only a year or two. Or,
right. Because a lot of the adult population have probably been dealing with this for years and years.
It's chronic,
and years.
Yeah.
So, okay. Any other differences in activities between children and adults? Or is it, I guess, if it all affects a kind of similar area?
No, I think the adults tend to have more of a history of back pain.
Yeah.
It's probably been months or years since their back pain was really their primary concern. And they're not linking it, obviously, to their GI issues. Adults, they'll kind of notice a little bit more, maybe positionally speaking, if they're in a car, if they're like kind of sitting but getting jostled, you know, up and down, like in a car or like a roller coaster or something like that, you know, they'll notice their symptoms come on with positional changes. Kids don't really notice that, you know, and I think partly it's just because they're not aware.
Yeah.
Yeah.
Okay. Anything else then with treating children?
I try to make it simpler with treating children. I try to make the sessions a little shorter. Just they don't have the attention span, and especially too, like with the parents, I try to make it easy on them. Like if I can get it to work with just like 2 to 3 movements, I'm not going to try to, I'm not going to try to expand too much outside of that. A kid will normally have enough tolerance to like 1 or 2 movements that you can get them to do. And you think about the parent. Think about you trying to get your daughters to do something every day.
Oh my God.
And so I'll normally have that talk with the kid, be like, this is on you, don't make it hard on your parents. If they remind you, make sure that you do it, stuff like that.
Yeah, I don't want to.
Yeah. Again, why I don't like treating children.
For sure.
Because not only are you treating the child, but you're also treating the parents. You're educating them and dealing with that. But
are the movements essentially the same?
Movements are the same.
Okay.
Yeah, movements are the same. Because the movements are built to target a specific area of your spine.
Okay, so what would you say then to someone out there who is a parent who has a kid, maybe, like, is there a specific amount of symptoms that have to show for you to say this is something you should maybe check? Or is it like one symptom? Do you know what I mean?
No, but so let's say it's one symptom. Let's say they're having mild amounts of diarrhea that's been lasting a few weeks, right?
Yeah.
And that's probably at the point where the parent's saying, hey, we need to get this looked at.
Yeah.
If they've tried some treatment, and normally, again, that treatment it's going to be some form of over-the-counter, supplement, medication, stuff like that. If they tried that and it's not working, here's a point where try looking at it a little bit differently. And again, from my viewpoint, if you give this treatment 4 weeks and you're not seeing improvement, that's fine. Now you've hopefully cleared the spine. You can check that box and say, it's not this.
Now let's move on.
And now let's move on to everything that you know is out there. But if it is that, not only are you able to improve the symptoms, but you've likely treated the underlying cause and you've done it without any medication whatsoever.
Yeah.
I feel like that's...
It's kind of the same philosophy of like checking to make sure it's not like cancer, or checking to make sure, you know what I mean? Like there's not a traumatic injury there before you move on to the next form of treatment.
Right. Before you do something that really can't be undone,
right.
Surgery or biologics or,
right.
Maybe consider this. So it's just kind of promoting that awareness.
So I guess if you're a parent out there and you have this and your kid's dealing with some sort of symptom like that and there's not improving, who do they go to?
So it's going to sound shitty if I say me.
Yeah.
But to my knowledge, I'm the only PT out there that treats GI symptoms.
Gotcha.
Pelvic floor, physical therapist, but they're still more focused on like the pelvic floor of it. To my knowledge, I'm the only physical therapist out there that treats GI symptoms by treating their spine. And I'm trying to change that. That's the whole point of being on TikTok and Instagram and this podcast. I'm currently writing treatment books so I can get my treatment philosophy and ideology out to more people at a more economic price, because to see me, it's more expensive, obviously. But if I can do a book or a video series, which the next video series and book that we're going to put out is going to be the GI one.
There you go.
Yeah, no, now I have to do it. No.
Yeah, no, I mean, the video series we do now, they're extensive, 60 plus videos.
Yeah, I pretty much design all of them to be like a 4-week course. Yeah. Within 4 weeks, again, you should have enough improvement that you're like, hey, this is absolutely helping. It's treating the underlying cause, and you should know where to go from there. Hopefully, I get you pretty close to 100%.
Well,
but if not, I talk you through, what the future looks like.
The thing that I like about them, I think the most, is that not only do you like give you the exercises and movements and explain why, but you come away understanding what's going on.
It's heavy on the education.
And so then when you're done and you are feeling better, if something flares up, or you know what to do.
People don't understand this because they're like, well, tell me what to do. And we could simplify and be like, look, I do a modified Jefferson curl primarily to affect that upper lumbar spine. I do other things, but if we want to simplify it, there it is. But that's one thing to know. It's another thing to know why. It's another thing to know like the little tiny changes in the movement. Like I just worked with a gentleman this morning right before this podcast. It's his 4th session. He had Crohn's. He's doing great. He actually had Crohn's and plantar fasciitis for decades, and his plantar fasciitis has been gone since visit 1. But we're on the 4th visit. He's been doing this Jefferson curl since visit 1, and I'm still making slight
changes,
modifications, right? And some of them are progressions, but some of them are like, hey, just you're losing your form a little bit here. And then also, like he actually said this today. He was like, I'm understanding better like the why. He's understanding like what he's doing throughout his day that's causing his symptoms, and that education of what to expect, why this is going on, what you should see in the future changes wise. Should you have to do this movements forever? Will you be sore? All that stuff, that's really important in the success of your recovery. Because if you tell me to do something, I'll do it. But if you tell me the why, I'll stick with it longer.
Yeah. So let me ask you this. What do you think the typical Crohn's Crohn's person would say is the reason why they have Crohn's?
Because they have an inflammatory condition.
But why do they have that?
Well, they can't explain it.
There you go.
Yeah. And, well, take it even a step further.
Yeah.
What would their doctors say of why they have that inflammation?
I don't know.
I don't know. Yeah, I mean, look it up. Look up why do you have inflammation if you have Crohn's or ulcerative colitis, and it's going to be a whole bunch of like, well, it could be this, it could be that. Multifactorial issue. Anything from genetics to environmental to lifestyle to diet to stress to medication to whatever, and it's going to throw all that out at you, but none of it really explains it.
It's overwhelming you with reasons, but not actually, or potential reasons.
Potential reasons, yeah.
Nothing that you can lock down. All right, well, I feel like, if you're out there and you have a kid who has this, you kind of have a better understanding of where you think that's coming from and what to do about it.
Well, again, where I think it could be coming from. I'm not saying all Crohn's or GI symptoms or ulcerative colitis or IBS is coming from your spine, but the patients that have come to see me, I'd say the vast majority of them have some form of spine issue. I'd say a solid 60% of them make significant changes with doing this. So again, it's not everybody. And there's some limitations too, like I do this program over telehealth, but it's not as good. I do still expect the same results, but I'd prefer to see somebody in person. It's a little helpful, especially for me to press on their spine. There's some consistency, issues, like some people are busy moms or busy dads, or or if the child like just kind of lackadaisically goes through their program, or if it's over the holidays, or if people have been traveling, or if they can only do 1 or 2 visits because of financial issues. Like there's barriers.
Yeah.
But even given all those barriers, even given the chronicity of these patients that have not responded to multiple treatments over years or decades, I still expect about 60% of them to get significant relief.
There you go. Also, I like the chronicity. That's good.
Another good word?
That's a good word.
What was it was the analogy. Yeah, we're using some, if I didn't spill coffee on myself during this.
Yeah, this would have been great.
We'd say this is a successful podcast.
Yeah, unfortunately, not quite there.
Yeah, hopefully people are just listening to this and not watching me stain with coffee.
I want to hear from people out there who have Crohn's and Crohn's symptoms, how long they've been dealing with it, what their symptoms are, and what they've tried.
Do you know what a lot of these people days look like? So you're talking about like commonality. Mm-hmm. Most of the patients are waking up to go to the bathroom, probably close to rushing to go to the bathroom. One guy, it was just kind of funny. He was like, well, I'm not running with my butt cheeks squeezed together anymore. Like, it was just like that term that he put. Probably somewhere between 5 to 15 times in the morning. I'd say that's the normal average. 5 to 15 times of having a bowel movement in the morning, so within the first 2 to 3 hours of waking up, that you're going to the bathroom that many times.
It's debilitating.
Yeah. Well, and think about these people too. Like, so the gentleman I just treated today, he said he doesn't hate food anymore. Yeah. And he's 3 weeks in, and I asked him to elaborate on it, and he said when he used to eat food, within a few minutes, he would have to rush to the bathroom. And if he's out traveling, like, not even traveling, if you're out at a restaurant, if you're out at somebody else's house, like if you're not at home base, right?
Yeah.
It's pretty awkward, to be able to have a bathroom, to be able to have some privacy in the bathroom, other people don't hear you.
Yeah, for sure.
It
would make you not want to eat out.
It makes you not want to eat.
It would be very hard and very difficult.
He said basically like he wasn't enjoying food because he knew what the cost was of eating was having to rush to the bathroom.
Yeah.
Yeah, and he said now he's not only enjoying food, but he's eating food that he didn't used to, and for him it was fruit. He said watermelon and something else.
Interesting.
Forget. I've had a good amount of people say fruit, but a lot of them it's, spicy food or pizza or cheese or dairy or something like that. Like that's probably the most common.
Gotcha.
But think about that. Like now you're actually able to eat food. So that's the final thing that really seems to improve is right around like week 5-ish, activity tolerance improves. Right around like week 6, and again, these are all generalities. Right around week 6, food tolerance tends to improve. Like now your body's healed up enough that you can have that piece of cheese or pizza, that you can eat your fruit, or what was the one that this patient was saying recently. I had another patient from Florida. I don't know. It was something that just wasn't common that she was avoiding.
So get that cheese.
If you want that cheese, you got to bend that spine.
Bend that spine, get that cheese, yeah.
Yeah. All right, any other questions?
No, no, but I think we do consider the title change of the podcast.
Just bitching about two guys
I could
complaining about children.
I could really go on about that. Yeah.
Same. And if you want to throw, spouses in there too.
Well, I don't even have that anymore,
I mean, that's.
that speaks for itself right there.
Right? It seems like you have a lot of ammo there.
But
two guys bitch about children. All right.
Name.
So that's our show for this week. Hopefully, we said some information that you were looking for, answer some questions. If not, you can reach out to us at info@thespinaltruth.com. You can go to our website, thespinaltruth.com, to schedule a consult or a session with me. You can look out for books and video series that are treatment-based that I'm currently and consistently working on to try to get out there. Stay tuned for next week. We are going to interview parents of a child that has gone through this process, that was diagnosed with Crohn's, that had years of symptoms, and you get to hear their story, what he went through, and what his experience was with treating his GI symptoms by treating the spine.